Paraesophageal hernias are classified into 4 types. Type 1 is the most common and is called a sliding hiatal hernia. Type 2 is where the gastroesophageal junction is below the diaphragm. Type 3 is where the gastroesophageal junction part of the stomach is above the diaphragm, and Type 4 has another organ above the diaphragm. We present a 56-year-old male with a Type 4 paraesophageal hernia. He denied any reflux or any history of trauma, but on his preoperative CT he had his colon in the right side of his chest. We begin the operation by reducing the colon below the diaphragm. There is a large hiatal hernia defect, and the stomach and duodenum are also gently reduced. We begin our dissection by taking down the short gastric vessels. The hernia sac is dissected off the left pleura. The pars flaccida is then opened up, and we begin the dissection on the right side. This allows for further dissection of the hernia sac. The hernia is measured at 7 centimeters in transverse diameter. We continue to mobilize the mediastinal attachments to the esophagus. The posterior dissection of the hernia sac continues with care to avoid injuring the esophagus. Once the circumferential dissection of the esophagus is completed, this reduces greatly the amount of tension on the esophagus and the stomach. The next step in this operation is to completely resect the hernia sac. Once the hernia sac is completely resected, we go on to complete our esophageal mobilization. There is still some tension on the stomach, pulling it back up into the mediastinum. Further mediastinal attachments are taken down, and then a Penrose drain is used to manipulate the stomach more effectively. The final posterior attachments of the esophagus are taken down. An endoscope was used instead of a bougie in the interest of safety. The crura are then reapproximated with a permanent suture. Both an anterior and posterior cruroplasty is performed. A piece of bioabsorbable mesh is also used as a reinforcement over the crural repair. A Nissen fundoplication was then performed. The intraoperative EGD showed that there was no evidence of injury to the stomach, and the patient went on to have an uneventful postoperative course.